Assalamualaikum warahmatullahi ta'ala wabarakatuh. So, me and my group mates will discuss the chronic obstructive pulmonary disease or the COPD. So, chronic obstructive pulmonary disease is also known as chronic obstructive lung disease, chronic obstructive airway disease, chronic airflow limitation, and chronic obstructive respiratory disease. So, chronic obstructive pulmonary disease refers to chronic bronchitis and emphysema, a pair of two commonly coexisting diseases of the lungs in which the airways become narrowed. This leads to a limitation of the flow of air to and from the lungs, causing shortness of breath. So let's take a look at this picture. So this picture shows us the normal lungs and the lungs with COPD. So in the first picture, we can see that the bronchioles and the alveoli are in good conditions, while the lungs with COPD, we can see and observe that the bronchioles lose their shape and become clogged with mucus. So, ang mucus natin dyan is yung yellow na part. And at the same time, yung walls ng alveoli is nasira. And also, nakabuo sila ng malalaking alveoli, which is not good. So, in COPD, less air flows in and out of the airways because one or more of the following. First, the airways and air sacs lose their elastic quality. The walls between many of the air sacs are destroyed. The walls of the airways become thick and inflamed, and the airways make more mucus than usual, which tends to clog them. So, let's proceed to the causes. Smoking is the common and usual cause of COPD. So, ito yung pinaka-common na cause ng COPD. Another one is the occupational exposure or yung mga workplaces, exposure workplaces, dust sa mga like gold mining or anything na exposed like chemical. So, yun. Yan yung mga occupational exposures. And then, yung mga air pollutions, then sudden air constriction in response to inhaled and irritants or yung mga tayo ng mga dust. And then bronchial hyperresponsiveness, which is a characteristic of asthma. And also the genetic alpha-1 antitriphosphine deficiency. So, let's proceed to the risk factors. So, risk factors for COPD. So, still, yung smoking is part of the factors bakit nati-trigger ang COPD. And advanced age, low socio-economic status, like for example, yung mga mahirap is nakatira sila sa mga places na exposed yung place nila sa mga gases like chemical gases na nakaka-affect sa kanilang lungs. And also the genetic factors na pwedeng namamana. And then air pollution, which is very common din kasi nakikita lang sa paligid or parating may mga pollution sa daan and everywhere. And also the developmentally abnormal lungs. So yung lungs natin is hindi siya na-form or in an abnormal yung lungs na kaya nagkakaroon ng COPD. So now for the pathophysiology, so the abnormal inflammatory response of the lungs due to toxic gases like the cigarettes, the chemical gases, the air pollutions, and others. So yung response natin is mangyayari siya sa airways, so sa parenchyma and pulmonary vasculature. So ang mangyayari, ang airways natin is liliit siya and magkaka-inflammation, and then at the same time puproduce ng mga mucus, lalabas yung mga mucus. And then after that, yung kapag nasira yung parenchyma, mag-worsen siya to emphysema. So ang emphysema is yan yung masisira yung mga alveoli natin. So the destruction also of the lung parenchyma will lead to an imbalance of proteinases or antiproteinases, which these inhibitors prevents the destructive process. So magiging imbalance siya, so hindi siya prevent ng mga destructive process. So mangyayari yung pulmonary vascular changes natin is the vascular changes natin is titigas, or the thickening, yung mga vessels natin is titigas, thickening of the vessels, and then yung collagen deposit, and destructive of capillary beds. So yan yung mangyayari sa pulmonary vascular changes. And then mag-ano siya sa mucus, yung mucus hypersecretion is yan yung mga cilia dysfunction, the airway or the airflow limitation, and yun. So kapag yun nangyari is yung airflow natin is malilimit, so magkakaroon tayo ng chronic cough and sputum production. So yeah.
I am Amra Farouk, and I'll be discussing about the bronchitis. Now, what is bronchitis? Bronchitis is a condition in which the bronchial tubes become inflamed. Now, there are two types of bronchitis. These are the acute and chronic bronchitis. So, acute bronchitis, it is the short-term type of bronchitis in which it is caused by the infection or the lung irritants. Now, for chronic bronchitis, it is defined as the presence of cough and sputum production for at least 3 months. So this chronic bronchitis is an ongoing serious condition, and it occurs if the lining of the bronchial tubes is constantly irritated and inflamed. So it causes a long-term cough with mucus. Now, let's look at the given picture. So on the picture A, it shows the location of the lungs and the bronchial tubes. As you can see, the bronchial tubes are located inside the lungs. Now, on the given picture, the picture B, it shows the normal bronchial tube. So, the normal bronchial tube is lined with a thin layer of mucus. Now, in the picture C, the bronchial tube with bronchitis. So, it shows that the bronchial tube is filled with increased amount of mucus, and this shows that this bronchial tube or this patient has a bronchitis. So let's proceed with the pathophysiology of bronchitis. Now, the irritants irritate the airway that will result into excess mucus production and will result into inflammation. Now, this inflammation will cause the mucus secreting glands and goblet cells to increase in numbers. Now, as they increase in number, the ciliary function is reduced and will cause the mucus production to be more. Now, as this mucus production is being produced more, the bronchial walls become thickened and the lumen will narrow, and this mucus will plug the airway. Now, the alveoli that is adjacent to the bronchioles may become damaged. Now, the altered function of these alveolar macrophages will be damaged and will result into infection and inflammation of the bronchial tubes. These are the signs and symptoms of the acute bronchitis and chronic bronchitis. For acute bronchitis, we have sore throat, fatigue or tiredness, fever, body aches, stuffy or runny nose, vomiting, diarrhea, persistent cough, cough that may produce clear mucus, and shortness of breath. For chronic bronchitis, we have coughing, wheezing, chest discomfort. The cough may produce large amount of mucus, and this type of cough often called as a smoker's cough. Now, for diagnostic evaluation, we have history or medical history in which the patient will be assessed if he or she had recently had a flu or cold, and he will be assessed if he or she smoke or spend time around others who smoke, or what we call the secondhand smoker. Then he will also be assessed if she or he has been exposed to dust, fumes, vapors, or air pollution. Now, the mucus will also be assessed to see whether he or she have a bacterial infection, and other diagnostic evaluation are the chest x-ray, lung function test, CBC, and the ABG analysis. Now let's proceed with the surgical management. So we have here bulectomy bullae, lung volume reduction surgery, and lung transplantation. So for bulectomy bullae, these are enlarged air spaces that do not contribute to ventilation processes, but they occupy large space in the thorax. So these areas may be surgically removed to lessen the effects of bronchitis. So next is the lung volume reduction surgery, in which it involves the removal of a portion of the diseased lung. So this will allow the function of the tissue to expand. So the last surgical management is lung transplantation, in which the diseased lung will be removed and will be replaced by a lung through transplantation. So let us proceed with the nursing management. So what we have here are the patient should take a rest. So the patient should have adequate sleep and should relax more. Then drink plenty of fluids. Headaches and body aches can be treated with pain relievers like paracetamol or ibuprofen. But this ibuprofen should not be given to patients who have asthma. Now, lastly, he or she should stop smoking or inhaling irritant. So that would be all for the bronchitis.
Good morning, everyone. I am Sitina Shivesman, and I'll be the one who will discussing the emphysema. So, emphysema is an enlargement of the air spaces distal to the terminal bronchioles with destruction of their walls of the alveoli, and it is a lung condition that causes a shortness of breath because the air sacs in the lungs or the alveoli are damaged, and the inner walls of the air sacs weaken and ruptured that create a larger air spaces instead of many small ones, and this reduces the surface area of the lungs and in turn the amount of oxygen that reaches your bloodstream and cause a shortness of breathing. Now, for the pathophysiology of the emphysema, so the alveoli walls are weakened and broken down by the increased protease activity that is a result of a chronic inflammation. And the increased protease activity causes the breakdown of elastin within the alveolar wall, result in distractions of alveolar wall is loss of elastic recoil within the alveoli and decrease in the alveolar surface area. So the alveoli are destroyed, the alveolar surface area in contact with the capillaries decreases, that cause a dead space or no gas exchange take place. And in result in increased residual lung volume, reduces expiratory flow and lead to hypoxemia. So in the later stage, the carbon dioxide elimination is disturbed, and increase in carbon dioxide tension in the arterial co- blood cause a respiratory acidosis, which is the decrease of the pulmonary blood flow is increased, forcing the right ventricle to maintain the high blood pressure in the pulmonary artery. Now, for the classification, first is the centrilobular, which is the respiratory bronchiole is expanded, and the distal acinos or the alveoli are unchanged, and it occur more commonly in upper lobe. And for the panlobular, it destroy the entire alveolus uniformly, and it occur more in the lower lobe and generally observed in the patient with the homozygous AATP deficiency or the alpha 1 antitrypsin. And this is what it looked like for the panlobular emphysema. There's a enlargement in the lower lobe, and for the centrilobular is the enlargement in the upper lobe. Now, how is emphysema diagnosed? So first is the history. There's a possible that one of the family member of the patient is having or have a emphysema that might inherit by the patient. The next is the spirometry and the pulmonary function test. Um, uh, in order to determine the airway blockage, and it tests the lungs volume by measuring the airflow while a patient is inhaling and exhale. Now next is the ABG analysis or the arterial blood gas. It tests a test to measure the amount of oxygen and a carbon dioxide in blood from an artery. Then next is the CT scan of the lungs in order to determine if there's any a defect or a abnormalities in the lungs. Then we have this screening of the alpha antitrypsin deficiency because the panlobular is commonly observed in the patient with a alpha antitrypsin deficiency. Then next is the X-ray. The X-ray radiography may aid in the diagnosis. It can help diagnose the moderate or a severe cases. Now, what are the risk factors? So first is smoking. Emphysema is most likely to develop in a cigarette smokers. Then next is age. Most people with a tobacco-related emphysema begin to experience symptoms of the disease between the age of 40 and 60, and exposure to the second-hand smoke, which is a second-hand smoke is smoke that you unintentionally inhale from someone else's cigarette. Then we have the occupational exposure to fume and dust. If you breathe a fume from a certain chemical or a dust from a grain, cotton, a wood, or mining product, you're more likely to develop a emphysema. Now, last is the exposure to indoor and outdoor pollution. And the common cause of emphysema is smoking, and it is not only destroying the lung tissue, it also irritates the airway. This cause an inflammation and damage to cilia that line the bronchial tubes, and this result in swollen airway, mucus production, and difficulty cleaning the airway. And all of these changes can lead into a shortness of breathing, which is one of the symptoms of emphysema is shortness of breathing. Now for the management, first we have the medical management, which is improved ventilation by giving a bronchodilator like beta 2 agonist and anticholinergic. Then next is methylxanthines and also the corticosteroids, then giving or administering oxygen to improve the ventilation of the patient. The next is remove the bronchial secretion. Then promote exercises, then control complication, then improve general health. Now for the surgical management, we have the blectomy bullae, which is bullae are enlarged airspace that do not contribute to ventilation but occupy space in thorax. This area may be a surgically excised. Now next is lung volume reduction surgery. It involved the removal of a portion of a diseased lung parenchyma, and this allowed the functional tissue to expand. Then last is the lung transplantation. Now for the nursing management, first is the assessment. You're going to assess the patient if there's any presence of anorexia, fatigue, weight loss, and presence of feeling of breathlessness, coughing, sputum production, flaring of nostril, use of assessing muscle of respiration, and also presence of dyspnea. And also if there's any presence of decreased respiratory excursion, we have also the resonance to hyperresonance, and the presence of decreased breathing sounds with prolonged expiration. And these are the possible diagnoses. We have the impaired gas exchange related to decreased ventilation and mucus plugs, and ineffective airway clearance related to excessive secretion and ineffective coughing. Then anxiety related to acute breathing difficulties and fear of suffocation. Then activity intolerance related to inadequate oxygenation and dyspnea. Then disturbed sleep pattern related to dyspnea and external stimuli. Then risk for infection related to ineffective pulmonary clearance. And last is the imbalanced nutrition, less than body requirement, related to reduced appetite, decreased energy level, and dyspnea. Now for the nursing intervention, first is maintain a patent airway. So use a humidifier to help the patient mobilize secretion. Then next is encourage the patient to use controlled coughing to clear the secretion that might have collected in the lungs during the sleep, and instruct the patient to sit at the bedside or in a comfortable chair and hug a pillow. Then bend the head downward a little and take a several deep breath and cough strongly. The next is place patient who are experiencing a dyspnea in a high Fowler position to improve the lung expansion. Then next is teach the patient pursed lip and diaphragmatic breathing exercise. Then last is instruct the patient to avoid crowds to avoid a contiguous infections. And here's the complication that might occur. First is respiratory insufficiency, then respiratory failure, then pneumonia, pneumothorax, and pulmonary artery hypertension. And tips for managing a COPD. First is take your medication regularly as prescribed. And if you have any doubt, then ring your physician. Then exercise regularly every day or else at least 4 out of 7 days. Then remember, take your vaccination regularly and stay away from infections by maintaining a good hygiene. Then quit smoking. Then eat regularly balanced diet. Then drink plenty of fresh plain water, at least 1.5 liter a day. Then get a plenty of sleep. That's all. Thank you.